Hi, folks, and welcome back to our interview series for Cancer Care Disparities from FLASCO. And my name is Dr. Jose Sandoval-Sus. I'm an assistant member at Moffitt Cancer Center on the Department of Malignant Hematology and Cellular Therapy at Memorial Healthcare System down in Pembroke Pines, Florida. And I am currently served as a chairman of the Disparities Committee with the Florida Society of Clinical Oncology, or FLASCO. So it's my sincere pleasure to host in this interview Dr. Maen Hussein regarding specifically in the topic of cancer care disparities. Who he has some experience here, advocating for the for our patients, especially the patients that minorities and so forth, their cancer care. So just to review a lot of the accolades of Dr. Hussein. First of all, Dr. Hussein is the chair of the Florida Cancer Specialist Foundation Board, the board of directors, and he serves as the vice president of our society of FLASCO. He is an oncologist up in the villages that is I would say mid western part of Florida. Very loved and very dear, cherished with all the community there. I know that for a fact. And he has participated in multiple clinical trials and was named the principal investigator for a recent, very important lung cancer trial in the community that he ran along with, obviously, with FCS and Sarah Cannon. And also has been, received multiple awards along his career, like the one in 2010, that is the Leesburg Regional Medical Center Outstanding Achievement Award, and in 2014, the Leesburg Regional Medical Center Foundation Hope in Healing Humanitarian Award, and a lot of other awards. And most important of all, he is the director of the finances of FLASCO. So he has a big responsibility on his shoulders. Just kidding. So man, welcome, and thank you very much for joining us. It's a pleasure for all of us having you here with us.
Thank you very much. It's my pleasure, and thank you for the kind introduction. For a while, I'm like, what are they talking about? But yeah, thank you very much. Yeah.
So, man, tell us a little bit of what we can do is that you can tell us a little bit about you per se, and then we sort of like take a deep dive into cancer care disparities and your experience with that, especially because you have been participating in national clinical trials in community oncology, and being also a PI on one of these trials. I just want to know a little bit about the participation of minority patients on these important oncology trials. And I know that you have been an advocate in the forefront of COVID infection, especially in cancer patients in your community and in Florida as a whole. So I'm going to ask you a little bit about that, if you don't mind, a little bit later. But first of all, tell us a little bit how did you get into oncology, into hemonc? I know that you are, like me, an international medical graduate, but we are all very curious to know what drove you, what was your calling to do oncology?
It is a funny story, because I used to hate oncology in medical school. I guess, it depends on your mentor. So the mentor was kind of, not very pleasant, let's be polite. And so I didn't study, I didn't care for him. So I had the chance, I went to the University of Jordan to study medical school. And in my last year, I had a chance to do elective in the United States. So one of the, I had the chance to do 2 months. So one of them, I picked hematology oncology because I had no idea what this is. And when I did that month in Nassau County Medical Center, that was in 1995, the summer of 1995. And I saw, like, back home, if someone has cancer, it's like a death sentence, not much you can do. And, it's very depressing. But I mean, I saw patients who are alive with cancer, alive after they've been cured with cancer. I was listening to all these lectures about, like, the new advances in oncology, the growth factor was just coming out. And that was, like, amazing at that time. And they were talking about all these, the studies in molecular antibodies. And so I figured that this is like going to be kind of the infectious disease of the next century. How 100 years ago, people get infection, we had no antibiotics, people died. And now we have all these antibiotics. I figured cancer is going to be so exciting. and it's still like kind of in infancy, and there's a lot you can do in cancer and contribute. You're not going to be coming to a science that's reached its peak, and there's not much you can do. So I figured that's what I want to do. I felt that there's a lot, yeah, and I kind of was right, because in the last 20 years there's been a lot of tremendous achievements and changes in cancer, and improvement in the quality of care, which is very important, the quality of life for cancer patients, and helping them live longer. So you can see a lot of patients who have stage 4 cancers, who if you see them on the street, you cannot tell they have cancer. They're golfing, they're in a restaurant, they're, that's why I got into oncology. I wanted to be part of something that I felt is going to have a lot of development in the next few years or decades.
Excellent, thank you. And remind me again, where did you train here in the US, or where did you do your hem-onc training here in the US?
I did my hem-onc training in St. Louis University in St. Louis, Missouri, SLU.
Okay, got it. So let me actually just reflecting on that a little bit. I'm meaning that, what you say is very important, right, in the world of oncology, because my experience was kind of similar in Colombia, right? I'm from South America, and I came here. I had a total different experience in terms of, cancer medicine, right, as a whole. So going, and this is sort of like where we take sort of like a bridge into our main conversation today about healthcare disparities in oncology. So what were, from your point of view, what if you compare it with the cancer care given in Jordan, right, to the one that you saw being given here, right, and maybe the one that you actually saw in when you're training, because actually that is and you correct me if I'm wrong, that is a community that might have a lot of minority patients, right, like in that area where you're training hem-onc. What were you thinking about? What were the main problems in terms of the treatment and the outcomes that you were seeing in minority folks with oncologic diagnosis and so forth?
So I think, for oncology patient, the difference is oncology is not a patient's disease. It's basically a family disease. And like if someone is diagnosed with high blood pressure, they don't call all their family and say, I have blood pressure and I need to take a pill and stuff. But if someone is diagnosed with cancer, everybody in the family would know. Like, even people you didn't talk to for years, you call them and you say, hey, I have, most of the time. So, and minorities have like, do have maybe stronger family relationships, especially like, African Americans and Hispanic minorities, and Middle Eastern too. Like they're very well tied and connected. So you can, like when you meet with a patient, you're really talking to the whole family. And I think what I felt that because they weren't presented well in clinical trials, I think one of the reasons maybe that there is no much trust in the health system, and you have to overcome that. And even when you recommend something to them, like they're kind of, asking all kind of questions, like, are you really giving us like what is really good, or are you hiding something from us? So you have to kind of overcome that obstacle. And when I first moved here, I worked in an area like in Florida, in the Leesburg area, a lot of African American, so there was compared to other areas, there were more than other towns in the area here. And I can see that. And one of the ways that I felt that, we can help with that is to try to find champions within the minorities. So that was like the tough way, to find someone who's educated enough and you gain their trust, because that's how I felt like, the difference between, or the obstacle that in treating minorities. And you try to have this person be the champion and be kind of your messenger to deliver, the information, maybe start some support groups and go to their groups, to their churches even, and give like, education and talks about like, what are the new advances, and encourage those patients to go into clinical trials. There is a bad history when it comes to clinical trial, and for instance, African American through the Tuskegee trial. So that's still like embedded in a lot of people's minds, and you have to overcome that, and to make sure that you're going to be treated just like the non-minority patient, and everybody's going to get the same care. And that can take time to take over, but really we have to keep trying. So.
Okay, great. No, actually, you jump ahead with one of my questions, but that's great. No problem, right? Because we're in the core. This is the meat and bone of this problem, I believe, identifying the problems, but also trying to find solutions, and, finding champions in the community, and, representatives of the community that can advocate for them, but also that can translate them what their healthcare team members are trying to express to them, and the importance of multiple things such as clinical trials and cancer care and follow-ups and so forth, right? Let me ask you a question. You're sort of like in a unique position because you are the first person that we interview here at FLASCO in this healthcare cancer disparity series that we're doing. The first person actually that works in the community, right? A community doctor, right? Community oncologists. We are the backbone of the cancer care in America, all right? Especially, well, at least in North America, right? So, right. But you're also in a sort of like a interesting position because you have through FCS, you have access to a lot of clinical trials in the community, right? So in the community, have you seen, what are your thoughts in terms of the participation of minority patients in clinical trials? Do you think there's a problem there? And how can we fix it? You already gave me one, but how else can you fix it, in your opinion?
Okay, well, yeah, so there is a problem. I mean, again, there is that trust, and it is changing. I've been here for 15 years. I can tell you it was much harder when I first came here to convince a minority patient to get in a clinical trial versus now. It's not much easier, but it's a little bit easier, but it's still kind of more difficult than a non-minority patient. And I think, the first thing you want to do is to try to gain their trust and not make it the first option for treatment, the clinical trial, make it one of the options. So, and get their curiosity to learn about it. Tell them, how the trial, why do you think this trial is promising? Maybe not even present it the first time, first talk about the disease treatments, make sure they get your confidence, make sure they're comfortable with you. And then, when you get the workup and now you want to talk about the treatment further, you can say, and by the way, we have that option, and explain to them, a lot of patients are worried about am I going to get treatment? Is there no treatment? Is there a placebo? And we try to explain to them that, no, you're going to at least get the standard of care. And I think it's just education. When I meet with a minority family, for instance, I try to find who in the family is the most educated, or who one that asks the questions, and who's the one that I feel like the maybe, I don't want to say most intelligence, but again, has the most experience or education. And I try to make them the champion to talk to their patient member, a family member who's the patient, about the trial. And that's a way to, and maybe even have another patient who has been through the trial, who's also minority, and use them to be after they go through it, to be a champion to talk to other people. So I use also my patients, because sometimes coming from another patient makes a huge difference. And if that patient is from the same background, it does help. So I think we need first to gain their trust and confidence. Again, go to their support groups, to their churches if we have to present the options of treatment and trial, and always try to find someone who you can maybe even share your email with them. Hey, you can ask me. I give my card, my email. Anytime you have a question, ask me. So this way they feel they have access to you, and the more they feel you're sharing things with them, the more comfortable they are, and they're more open to be to your any suggestions or recommendations. And I think again, once you have one or two of those patients in each minority that you gain their confidence, you can use them in the future to help you with other patients who are part of that minority.
And let me ask you a question in terms of that. That's very interesting, and I totally agree that will be a very useful alternative, and it has been proven actually. What you're saying, right? That champions in the community, but right. from the standpoint and from the your sort of your vintage point from in the community. What do you think about in general, right? And this is a big brush, right? Of the inclusion exclusion criteria of our current clinical trials, because a lot of the treatment that we use for cancer care, they comes from trials that are done in big, cancer centers, institutions, and whatnot, where they usually see these quote unquote patients, but there are patients are to get there, they're sort of like super Olympians, right? Perfect kidney function, perfect liver function. You can drive back and forth, right? And so forth. In the community, don't you think they're a little bit restrictive? I mean, what would you do? What would you propose to do about that?
I think we give that feedback actually. Like when I do when we talk about a trial, I want to be a PI or a sub PI, and then we have the interaction with the sponsor of the trial. We do give them that feedback when we feel like, this is not going to work here because most of the population here at that age or this race and these numbers may not fit well. Like for instance, in African American, you can have neutropenia or leukopenia, and that's normal for them, right? I mean, their white cell number is usually lower than other races, and we try to give them that feedback so they can work. And I can tell you, sometimes it works and they can make some changes, and sometimes it doesn't. And then yes, that can be restrictive, but you just have to keep trying. You have to keep educating even the sponsors about your community. And I always take that chance to tell them, this is not going to work here. This is going to work. You have to make that change, and please go back and see if your supervisor or the one in charge or whoever wrote the trial can make those changes. And I can tell you, sometimes it does work. It's just you have to be persistent. It's like a change of culture. You have to change that culture of like everything has to be perfect, because that's not the community how normally people are. Like, people are not perfect. They're not going to have a perfect kidney function and perfect liver function, and they're always going to have some kind of deviation, and we have to allow some of that.
And in your experience, do you think it might be getting better?
I think they're more open to listen and to, because we, and further, like with sometimes the same sponsor, like the next trial, they do say, by the way, now we're allowing this or allowing that, or if clinically, if this was their baseline, we will allow it, and just like, let's look for a change in the numbers,
Well, that's good to hear. I mean, and I hope
it's not much. I mean, it's still an infancy again, but I mean, we need to be persistent and keep doing that.
I can tell you at least a lot of our, partners and colleagues from the industry are, I listening to all of us, especially everybody in the community, and I think there might be some urge and some movement for change, which is good. I'm going to change topics a little bit and talk a little bit about this that is affecting, of course, everybody, is this COVID pandemic that we still 2 years ongoing, right? And I know that you have been very vocal and trying to advocate for your patients and the patients in Florida. In your experience and in your community, tell me how, and we know that this has been a problem across the board, across the United States, but how in particular has COVID affected oncologic patients, especially minority patients with oncology diagnosis?
The problem with minorities, again, they're also the ones who are suspicious of the vaccine. So most of them are, unfortunately, are not vaccinated. So again, education comes here. The other thing, like those cancer patients or patients who don't have cancer are afraid to do their screening tests and colonoscopies, and now we're seeing cancers in more advanced stages. Or even if they have cancer, it's hard to treat them because you don't want to make them, change them to become immune compromised. And if they get COVID, it's going to be hard. And unfortunately, the area that I live in, we have a lot of people who are resistant to the vaccine. But one of the things that helped me convince many patients or even, friends or even staff to change their mind about vaccine. First of all, I don't focus just on the vaccine. I say, the vaccine, nothing is 100% protective. The vaccine is one part we do. You still have to do social distancing, masks, hand washing. They all work together. And one of the problems in what's happening in the country is like, if you don't disagree with me, then you're an idiot. That's how people are treating each other. Mm-hmm. And I try to educate and not make them feel stupid or show them, oh no, you're just an idiot. I'm not gonna. You just have to listen to me. I try to, when patients have a hesitancy to get the vaccine or not follow, or have, questions about the COVID. Some of them think it's a hoax and stuff, and say, what are your questions? What is bothering you? Let me help you with the knowledge I have. And they ask their questions, and I just discuss them with them like in a logical way and not the demeaning way, because that's the important. Once they feel like you're becoming demeaning to them, that's when they become more resistant and they stick to their mind. It's a human nature, right? Mm-hmm. So I try to make it like back and forth. And I say, you know what, I respect your opinion, but let me tell you the science. And one of the things that I use, and I find it helpful, because people say, well, the media says this. Look, listen, I don't watch any of the media. I can tell you I have groups of physicians that we work together. All kind of physicians that, we consult together and stuff.
So
colleagues' experiences. I've been going to the hospital the last 2 years. I've seen how certain measures help in lowering the numbers. Like, when the vaccine started, the numbers started going down, people stopped vaccinating, numbers going up. I mean, so I tell them about our local experience. It's closer to home. And I can tell you, some people will never change their mind, but a lot of patients will start thinking. Even if they become resistant to you there, when they go home, they will start thinking about it. And, they just don't become in an attack mode. Don't just, I try to definitely remove politics, and I try to be as an educator and, not a challenger. I have many patients who email me, oh, did you watch this video? Did you read this article? And I reply in a scientific way. You know what this doctor said, part of it is right, but some parts are not, because this is how this works, and this is what the data show. And unfortunately, this doctor is using certain knowledge just to give the wrong message. And that happens, unfortunately. And I tell them, listen, we are still learning, because one of the problems is that people say, you keep changing your mind. You doctors keep saying this and that, no mask, put mask, do this, don't do that. And I say, well, you are looking at the evolution of medicine in like a very short period. Like, for instance, like, years ago, they said, women should take hormone replacement therapy. Then I remember when I did my internal medicine board, they said, oh, there's new data showed that, maybe women shouldn't take it. But when you have questions, don't answer according to the new data, answered according to the old data. Same thing when it comes to cholesterol management, or taking aspirin or not taking aspirin. But these things can take years to learn, because we have a pandemic. We have kind of the luxury of having a lot of people getting infected, and we're learning at faster pace. So yes, we do change our mind, but not because it's an opinion, because we are looking at facts, we get more data, and that's how we come up with the recommendations. So I tell them, you're basically looking at warp speed, evolution of how medicine works. So I mean, again, education is very important, but in a nice, not challenging way. I think that's how you get to, especially the minorities, because you want to include them, you want to get their trust, and you want to show them that you are doing it because you care about them, not because you want to prove that you're right. It's not a Facebook argument. It's, I really care about you, and I want to tell you why I think this is good for you.
It's not, you're right. It's not a social media argument. Yeah, Facebook, Twitter, whatever you name it. But you're right. Being an educator, meet the patient in the middle, right? Like trying to help him out in every way you want. Yeah, absolutely. Great. And I was going to ask, how you're a very important person in FLASCO, and you're very, like I said, you are vital. You are vital to our society. So what would you say that FLASCO as a society, right? Of clinical oncology here in Florida, one of the biggest, is the biggest society of oncology outside ASCO, right? What can we do to try to close the gap in the cancer disparities in Florida and potentially in the United States, but at least in Florida?
I think one of the proud moments of FLASCO, I mean, I saw with FLASCO around maybe 8 or 9 years ago, and one of the programs that I work with some people to start is the Navigator program. And I can tell you there's a lot of minority navigators in this program. And now we're seeing more minorities as physicians, nurse practitioners, PAs, and those come to the meetings. And I think we need to involve them more. That's how FLASCO can work. We have to give a voice to those people. And, I'm very proud of our organization, how we are really we're not just focusing on physicians, we're focusing on all the parts of the medical team, the PAs, the nurse practitioners, the navigators, the pharmacists. I mean, all these people have a role in our planning and what programs we do, and the outreach, and they go and educate and teach. So we need to do more of that. We need to partner with pharma to help us do more of that, and partner with other organizations, not just pharma, to help us do that and educate. And our role should be mostly to educate about the new changes, the clinical trial importance, and how to manage things like the pandemic and COVID patients, and how this important to educate patients about it. So I'm very optimistic about the future of FLASCO.
Excellent. Thank you very much. We as well. One thing that I wanted to ask you, and we're almost done, and thank you very much for your valuable time. All right. But we almost done here, and I wanted, you and me, all of us know that there is a shortage of oncology healthcare practitioners around the country. Not only oncologists, right? But also nurse practitioners, nurses, like you said, navigators, and so forth, taking care of cancer patients across the US. Yeah. What would be a message that you will convey to the future people, especially, medical students, nursing students, and so for internal medicine residents, so forth, that why do oncology in this day and age in the United States?
So many people think oncology is depressing, but I can tell you, oncology have this, give us this satisfaction that, it's probably the only specialty that you can give someone bad news and they still hug you and say they love you. And that the idea is to help patients live longer is great, but also the idea is to help patients to accept sometimes really bad news. And the other thing is oncology is gonna still see a lot of developments and a lot of advances. There's gonna be one day where chemotherapy is gonna be obsolete. And I always joke about this Star Trek show where they were in one episode they had these records from the 20th century, and one asked the other, he was reading, it's like, and the patient got chemotherapy, so he asked the doctors, what is chemotherapy? It's like, oh, those were the savage days, we used to treat cancer with chemotherapy. And I can tell you, maybe we don't have to, yeah, we don't have to wait till Star Trek happened. I think we, in 20, 30 years, we might say that. We might say, you know what, when I was a fellow, we used to give these drugs that you lose your hair, you throw up. Now we just take a pill or take this immunotherapy and you're good. You control your disease. So the future is very bright, be part of it. That's what I would tell them. I have few students from UCF who did rotations with me, and at least one of them is gonna do oncology, the other one is thinking about it. So I think they are seeing that message. They're seeing like the same message that I saw when I was a medical student, that there is future in oncology, there is a place to make a change. So if you wanna be part of that, making history, this is the field to go into.
Excellent. No, and this is an excellent message, and I wanted to resonate across everybody because we also, if there's a challenge getting medical students and residents to do oncology, there's even more of a challenge of minority physicians and practitioners in oncology. That's really a mega challenge. So hopefully, FLASCO can also put a little bit of a role on that, educating, making sure that more and more students get into FLASCO, students and residents and so forth, all into our activities and so forth. So last but not least, it has been a hard 2 years for everybody, right? Especially, healthcare workers, but for everybody in general. Tell us a little bit about what do you do on your free time just to decompress, just to avoid that unpopular but almost very prevalent burnout that we're seeing nowadays.
So there are two things that I do just for myself. Everything I do either for family or for patients. The two things I do for myself is playing soccer. So I play once a week, at least for a couple of hours, and it's at night and the weather is nice. And the other thing, you're gonna laugh, but it's building Lego sets. I'm a big Lego fan.
Me too.
I have, oh, great. Yeah, so Lego sets. These are the two things. I mean, Lego drives my wife crazy because sometimes you have pieces still on the floor and stuff, and there's no place to put them when you build them. But those are the two things that and sometimes I watch like TV or streaming some shows and stuff. So. But those are the two things that I feel are just like for me. This is just to no medicine, no family. This is just me.
Excellent. Well, I'm also a fan of Lego, and we just bought the last one from Star Wars, but you're right. It's really crazy when you step like barefoot and step on a Lego piece. Oh my goodness. Okay, I can't tell you about it. But well, Maen, there you have it, Dr. Maen Hussein, folks. It was a pleasure having you here in our series of cancer disparities here at FLASCO, and sponsored by the Disparities Committee. Just Maen, any words to go now? Any closure here that you want to leave us with? Any words of wisdom?
Well, I want to thank you very much for having me, really. And I think the word of wisdom, one of the things that I think as an oncologist we do is always to look for the good in the bad. Because we're used to give bad news, we get sometimes a lot of bad news, and we have those days where we feel like down because we have to give bad news. But try to always find the positive and the negative. And I think if you apply this in anything in life, your life will get better, even mentally and psychologically. So if any advice that people can remember from what I said is try to always find the positive in the negative.
Okay, there you have it, folks. Dr. Hussein from FCS and from our dear Physician Director of Finance at FCS. Thank you, Mike. You have a very good day.
Thank you. Bye-bye. Yeah.